Hello everyone, my name is Yann. I'm grateful for this opportunity to briefly present our study of immunodeficiency and cancer in people living with HIV in South Africa. I will state that this work was presented at the CROI conference last month. The relationship linking HIV infection, immunodeficiency, and cancer has been studied extensively over the years. Despite this relationship is still not fully understood. Furthermore, a lot of these studies have focused on the so-called AIDS-defining cancers, such as cervical cancer, Kaposi sarcoma. Studies on the other types of cancers have been less common and have often been restricted by a limited number of cases, especially in regions like sub-Saharan Africa. Our aim was to perform a thorough evaluation of associations linking immunodeficiency, as measured by the CD4 cell count, and the risk of cancer in the HIV-positive population of South Africa. To achieve this, we were fortunate to have access to a very large nationwide cohort of people living with HIV, a cohort called the South African Cancer Match Study, or SAM study for short. This cohort was built from a linkage between lab records, specifically HIV test results, and cancer diagnoses from the South African National Cancer Registry. For our analysis, we restricted the study population to adults having at least 1 year of follow-up and 2 separate CD4 cell counts. We computed hazard ratios for the incidence of cancer using Cox proportional hazards models. This was done separately for a wide variety of cancer types, including both infection-related and infection-unrelated cancers. Our main risk factor of interest was the CD4 cell count, which we modeled using a longitudinal approach, essentially updating at each new CD4 cell count. For the analysis I will be showing here, we assumed a linear relationship between CD4 cell count and the log hazard. Our study population consisted in over 3.5 million patients, giving us over 9 million person-years of follow-up. Most of the patients were women, and the median age was 34 years old. Of these patients, 15,000 developed an incident cancer. You can see how these cancers are distributed in these two tables. Infection-related cancers on the left, infection-unrelated cancers on the right. The most common cancer was cervical cancer, with almost twice as many cases as the next highest, which was Kaposi sarcoma. And among the infection-unrelated cancers, the most common cancer by far was breast cancer. In these two forest plots, you see the hazard ratios describing the association between CD4 cell count and the incidence of the different types of cancers. These hazard ratios are given per decrease of 100 CD4 cell count. We found the strongest association to be in the case of conjunctival cancer, where the incidence rate increased by a factor of 1.5 for each decrease of 100 CD4 cell count. We also found an association with some of the other infection-related cancers. That said, we found no increased risk of bladder and stomach cancer in patients with lower CD4 cell count. In fact, even a decreased risk of stomach cancer. As for the infection-unrelated cancers, there was marginal evidence of lower CD4 cell count being associated with higher rates of melanoma, of cancer of the esophagus, and of colorectal cancer. I will also mention that in the case of non-Hodgkin lymphoma and Kaposi sarcoma, the association with lower CD4 cell count was stronger in women than in men. So based on this large-scale study of people living with HIV in South Africa, we found that lower CD4 cell count was associated with a higher risk of several infection-related cancers. That said, we did not find a markedly increased risk when it comes to the infection-unrelated cancers. The burden of infection-related cancers is quite high in South Africa, so reducing immunodeficiency in people living with HIV could be a good strategy to reduce cancer incidence in that region. To close this presentation, I would like to thank my co-authors as well as the institutions who collaborated on this project. Thank you.